Hi, my name is Vivien Wittstruck, and I'm a junior at Freedom High School in California, the United States of America. This is my presentation for the International Youth Researchers Conference. I conducted a systematic review researching how lung cancer outcomes can be enhanced through preventative and early detection strategies in the U.S. Lung cancer is the leading cause of cancer-related death worldwide, reaching around 1.8 million deaths in 2020. Early detection through public health interventions, such as low-dose computed tomography screening, a type of X-ray, has been shown to significantly reduce lung cancer mortality by identifying tumors at a treatable stage. However, despite advances in screening, many people are still diagnosed at an advanced stage when curative treatment is no longer possible. This graph displays the 5-year relative survival rates from 2015 to 2021. We see an overall trend that lung cancer that was detected at earlier stages, where the lung cancer had not spread as much, had a greater survival rate. This truly emphasizes how significant it is for early detection. To identify how we can strengthen these prevention and early detection efforts, my research goal was to review evidence on current strategies, evaluate current programs, and identify gaps and opportunities for improvement. This study was designed as a systematic review aimed at synthesizing original research on preventative and early detection strategies for lung cancer within the U.S. The PRISMA guidelines were followed to ensure transparency and reproducibility throughout the review process. A total of 241 records were identified, with 14 studies meeting final inclusion criteria after screening. Inclusion and exclusion criteria was created to ensure that only relevant studies focused specifically on prevention and early detection strategies regarding lung cancer were included. Studies where this was not the primary focus, such as where sex or race-based disparities, economic evaluations, awareness campaigns, treatment strategies, or on specific subpopulations where the primary focus were excluded. Some limitations of the screening process to take into consideration is that only one database was used, potentially omitting relevant studies. Publication bias is also possible, as studies with no findings are less likely to be published. Restricting searches to English language publications may have limited international research inclusion within the review's criteria. Finally, the screening process was conducted by a single reviewer, which may introduce selection bias. The findings from the included studies were synthesized into 3 main themes: effectiveness of LDCT in early detection, combined screening and smoking cessation interventions, and expanding screening criteria beyond traditional risk groups. The first finding across 9 studies was that LDCT screening was shown to be associated with significant improvements in early detection and lung cancer-specific mortality, demonstrating the efficacy of LDCT screening in early detection. LDCT screening was effective in reducing the risk of mortality and mortality rates in patients with NSCLC, with the more aggressive SCLC type still needing even earlier detection. Modeling studies have projected a 20 to 24% reduction in mortality for eligible populations undergoing annual LDCT. These findings have shaped clinical guidelines, such as the U.S. Preventive Services Task Force's recommendation for annual LDCT in adults aged 50 to 80 with a 20-pack-year smoking history, which is smoking 20 cigarettes a day for a year, and currently smoke or have quit within the past 15 years. Additionally, recent experts have recommended integrating AI and improved radiology infrastructure to enhance LDCT's diagnostic accuracy and accessibility. This is because of AI's potential to enhance the scan time speed, accuracy, and sensitivity of lung cancer nodule detection, which will thus lead to improvements in identifying and predicting the risk of malignancy in a lung nodule. Second, 3 studies emphasize that combining LDCT screening with smoking cessation intervention enhances overall effectiveness. One study conducting a randomized trial found that telephone-based cessation counseling combined with screening significantly increased quit rates among current smokers. The increased reach and tailorable aspect of the telephone counseling allowed for the cessation interventions to be more intensive yet cost-effective. 2 other modeling studies projected that pairing screening with cessation could reduce lung cancer and mortality more than screening alone. These findings position lung cancer screening as a crucial teachable moment when the patient may be most receptive to changing their health behaviors. This approach both promotes smoking cessation and maximizes preventative impact, which will be particularly beneficial for long-term and current smokers. Third point addresses future directions. Several studies challenge the sufficiency of current eligibility criteria, particularly for people outside the traditional high-risk group, as defined by the U.S. Preventative Services Task Force current recommendation. Two studies noted that lung cancer was incidentally detected in patients who were either too young or too old for current screening guidelines, despite a majority of the patients having a low or non-smoking history. One influential factor outside of smoking is family history. Those with close relatives who had had lung cancer may have a higher genetic predisposition. We must also take note secondhand smoke is the third most common cause of lung cancer in the U.S., and nearly half of lung cancer cases in people who have never smoked are estimated to be related to air pollution. So clearly these are significant risk factors, yet are currently not accounted for in current screening criteria. One study also suggests that the lung nodule detection method, which identifies small lung nodules by imaging, assesses their characteristics, and follows up accordingly, may be more effective in early screening and timely diagnosis than LDCT screening. This program catches nodules in a wider range of patients, including those not eligible for LDCT, uses risk stratification including AI tools to estimate malignancy, and ensures that nodules of concern are strictly followed up on. As a personal project, I conducted a digital intervention to determine effectiveness in education to increase awareness of lung cancer risk factors. During this intervention, I presented reliable evidence-based data to introduce and promote LDCT screening for early detection, encourage behavior change, and reduce stigma regarding lung cancer. This intervention was open to the nation, receiving 46 responses from geographically diverse locations across the U.S. 3 responses were excluded due to invalid responses, thus 43 responses were included in the data analysis. The intervention was structured as a pre-post test, with participants completing a questionnaire consisting of 6 true or false questions. To evaluate the effectiveness of the intervention, a paired two-tailed t-test was conducted, and the results were promising. A p-value of 0.0104 was yielded, which is statistically significant at alpha equals 0.05. Indicating a meaningful improvement in participants' overall understanding after the intervention. Across questions, an average of 4.83 participants improved from incorrect to correct per question, while only 0.5 regressed from correct to incorrect, for a net positive shift of 4.33. No question showed more regressions than improvements, underscoring consistent directional gains. Question 5 on the survey, which asked about lung cancer as the leading cause of cancer deaths, drove the largest impact with a delta of +9. These statistically significant results highlight the effectiveness of the intervention in correcting key misconceptions, and contribute to the idea that educational interventions can have a significant impact in increasing awareness. So overall, the findings of the systematic review highlighted how advancements in screening, behavior change interventions, and broader eligibility criteria together offer critical opportunities to increase lung cancer prevention and early diagnosis. Now I'd like to move on into the discussion and talk about how we can take these findings moving forward. Based on the observed strengths and weaknesses of LDCT screening highlighted in the results, I have identified 2 public health avenues for improvement to maximize early detection of lung cancer in the U.S. Within the 2 main types of lung cancer, LDCT was particularly effective in detecting NSCLC. However, it seemed to be too late in detecting the other main type, SCLC. This is likely because SCLC grows much faster than NSCLC, often spreading past the lungs by the time of diagnosis. Current screening recommendations leave non-smokers or people outside the 50 to 80 age range vulnerable to late lung cancer detection. As a result, non-smokers may be less likely to seek screening and are therefore less likely to detect lung cancer early. One solution to this disparity can be to incorporate the lung cancer nodule to be used in conjunction with LDCT into U.S. lung cancer screening practices to expand early detection. This would ensure that Americans aged 35 and up can be tested for lung cancer early on, regardless of smoking history, therefore resolving the issue of low-risk groups being vulnerable to a late diagnosis. Second, another key issue involving LDCT screening is the extent of insurance coverage. LDCT is made affordable for patients by most insurance plans in the US, but if the patient does not meet all the listed requirements, then they are ineligible for full coverage. Once again, this highlights the significance in increasing the accessibility of LDCT screenings for the wider population. To achieve this, there are two approaches that could be pursued through legislation. By passing legislation that requires insurance providers to cover more preventative health services, including LDCT screenings, people will likely be more motivated to seek these services because they know they can afford it. Working with policymakers at the state and federal level to pass legislation that ensures national full coverage of LDCT screenings will be monumental in increasing early lung cancer detection. Here's the second approach. While it may be costly for the U.S. employees to fully fund LDCT scans for all employees between the ages of 50 and 80, following the Japan model of workplace health checks can encourage discussions and make risk groups more aware of how to navigate their health insurance policies to seek the help they need. Based on the research evaluated in the systematic review, LDCT screening is crucial to promoting early detection of lung cancer. However, its weaknesses, such as lack of accessibility to non-traditional groups, means that a broader detection system such as the lung nodule program should also be incorporated. In addition, the costs of LDCT are still not fully covered for everyone in the US, so a public health initiative to increase screenings could be to pass legislation that increases full insurance coverage access and mandatory health checks at the workplace. Here are the primary references I used for this study. Thank you. If you have any questions or comments, please feel free to email me.